Dear Pure Urology viewers, good evening, one and all. As you all know, Pure Urology Facebook group is doing either alternate day or like that, urology surgical technique related programs. And we are sharing the link in the Facebook Pure Urology group. And those friends who have not joined, you can inform them. If they are urologists, they are most welcome. Today, the topic is supine PCNL. As you all know, way back in around 3 decades back, supine PCNL was propagated, but not effectively after that. In 2007 onwards, once the RIRS has picked up, people have looked into the combined uses of RIRS and supine PCNL. Many seniors like Cesar Scaffone have done a lot of research work, and now recently, last 10 years, supine PCNL has come back because of its advantages combined with RIRS. All the stones which can be dealt by prone can be dealt by supine is the argument. Today, we wanted to learn the puncture techniques in supine PCNL. As you all know, various positions are there in supine PCNL, various puncture techniques are there. For that, we invited Dr. Mehmet ilker Gokce today for this program. He is from Turkey. So we will take brief information about his surgical career. Then I will present his curriculum vitae, and then we will hand over the program to him. Very good evening from India, Dr. Mehmet. Thank you for accepting the invitation for Pure Urology. Hi.
Hi, Dr. Chandra. It's a real pleasure for me to be with you today. Actually, I hope it's going to be a great program. You are doing very well with this Pure Urology program, and there are a lot of followers in Facebook group, as I have seen previously. And also the programs are usually well selected with well-selected speakers, and you are doing a great job. And I just want to thank once again for the invitation. Thank you.
Thank you. Regarding your surgical career, when did you develop interest in surgery? Who is the mentor for you?
Okay. So during the medical school, I was actually just decided to go with surgery, and my interest in urology developed during the medical school. And I actually graduated from Hacettepe University in Ankara, and then get my residency in the Ankara University. That's just across the street. And I also spent some time during my internship in that hospital, and then I decided to do urology in that hospital. And actually,
you
Professor...
training in Turkey, entire your surgical training is in Turkey?
Yes, my entire residency has been in Turkey.
What is the tradition of training in Turkey? How many years MBBS and then internship and then to become urology consultants? How many years we have to get training?
Actually, the medical school is for 6 years in Turkey, and it also involves 1 year of internship. And then we just applied to a central examination for matching to the residency programs. And the urology residency program takes about 5 years in Turkey, and it's almost the same in every part of the country. It's 5 years.
A lot of research work related to stone from Turkey. Phenomenal research. Even advanced surgical techniques, innovation, thinking, small sheets, pediatric RIRS, supine PCNL. It's a stone surgery is famous in Turkey, isn't it?
Yes, absolutely. We are in the stone belt, so the prevalence of stone disease in Turkey is about 14% of the population. So, and it's more than 80 million population country, so there are a lot of stone cases, and every urologist is actually quite interested in stone surgery here.
When did you learn your supine PCNL? How did it happen? Because 90% of the world does prone because teachers are prone, students are prone, thinking process is prone, and we are not able to think other thing. How did it happen to you?
Okay, so during my residency, my mentor, Professor Mutshafak, also trained us in prone position. And we learned a lot from him. But I always had some issues with the patient positioning. It takes a lot of time, and also had some struggles with the anesthesia. during some of the operations. And also I was very interested in combined surgery as well. Tried doing the ECIRS in prone position. It's possible, but it's really doing something very easy in a complicated way. So I decided to shift the supine position. And till after that, for the last 8 years, I'm doing all of my surgeries in supine position. And prior to that, for 2 years, I did some prone, some supine, and then...
When you first did your supine puncture, is it yourself imagined or one of your teachers were doing the supine PCN? How did you do that?
I actually started by myself and just went through some online programs and courses like this one. And but I was the first to do the supine PCNL in my hospital, and actually it was sometimes it was at that time it was hard to just shift from prone to supine, but when you get used to it, what I can say is there is no way going back.
Very nice. Actually, I met Dr. Mehmet in Canada previously. We used to interact through the social media only. One thing a lot of people ask, is there any bullseye in supine PCNL? He has given a good video in that. I was impressed, and then we got connected. To be honest, his presentation in 8 minutes was very crisp. Today, we don't have time limit. Let us share even in your question box. You can ask questions because this is upcoming part in the stone surgery. So Dr. Mehmet, to introduce, Associate Professor of Urology, Ankara University School of Medicine, Turkey. Clinical work includes only endourology, especially supine PCNL, ECIRS, and HOLEP. He continued his studies, especially on endourology and urinary system stones, during his residency training. Associate Board Member of ULIS, Coordinator of Supine PCNL Working Group of International Alliance of Urolithiasis. He was entitled to receive 2,219 overseas postdoctoral research scholarships given by TÜBİTAK. Great. He has a surgical experience of 4,000 cases only in stone surgery. Board member of Society of Minimally Invasive Surgery in Turkey. Published 120 scientific papers in various international journals. Really good CV. And I am very fortunate to have you, who is specialized in this subject. And you know, in India, it is now a good, recently very hot topic. Lot of arguments, lot of debates, and people are coming out with supine PCNL, more number juniors particularly, and enjoying ECIRS. So with that context, I hope the talk today will be very useful for the youngsters. Over to you, Dr. Mehmet. Thank you very much once again for accepting the invitation.
Okay, so thank you again for this nice introduction and invitation. And I'm just gonna share my screen now. And today I'm going to be talking about the puncture techniques in supine PCNL. As I mentioned before, I was trained in prone position and then shifted to supine. In the initial phases, I did some of the cases in prone and some in supine. Usually started with some simple cases in supine, but then shifted to entire practice into supine position. And I now believe that you can do anything in supine position that you do in prone. There is no limit. And in today's presentation, first of all, I'm going to talk about the puncture techniques in under fluoroscopy guidance, and then try to give some tips and tricks on the ultrasound guided puncture. And also with the help of the ECIRS, we can do the endoscopic guided puncture as well. And we can combine all of these. So I'm going to show some examples with the videos. And in the end, if we have some time left, I also prepared some cases for some special situations. Yeah. For example, the upper pole puncture is mainly given as a problem in supine position, but I'll try to provide some tips and tricks in this manner. And also a case of horseshoe kidney, and also an ectopic kidney, again, under endoscopic vision. So related to this topic, I have no disclosures. And as you mentioned previously, first of all, I'd like to thank these pioneers of the supine PCNL in the history. First of all, Dr. Valdivia Uria, who first introduced the supine position, and then Dr. Gaspar Ibarlezia from Bilbao, who introduced the use of retrograde ureteroscopy together with the PCNL. And together with him, Dr. Cesare Scafone, who introduced the terminology of endoscopic combined intrarenal surgery to our routine daily practice. And to be honest now, I believe that flexible ureteroscopy is an integral part of PCNL, and almost every case in my hospital are prepared as ECIRS, even the very simple cases. So first of all, I would like to start with the patient positioning. This is a crucial step and maybe one of the most important steps of this procedure, because if you have your position nice, then doing the puncture is also easy. We almost always use this Galdaka modified supine Valdivia position. And in this position, first of all, we draw a line to the posterior axillary line, and then put the bolsters one under the gluteal region and one under the chest. And by this way, the flank region is elevated, and there is a lot of space here. There's no problem with this space, and you can do the upper pole punctures as well. As you can see, the space is quite good. And then we put the legs in the modified lithotomy position, and by this way, doing the retrograde access is really easy. And this video is a real-time video that how we position the patient. It takes just about 45 seconds to put the patient in this position. We draw the line in the posterior axillary line, then put the bolsters under the gluteal region and also one under the chest. And then we just turn the patient very slightly, 5 to 10 degrees. And at this time, we do not like to pull the patient to the very edge of the operating table. This is really important because there are some metallic bars located in the lateral parts of the table, and they may interfere with the fluoroscopic images. Then we put those legs in the modified lithotomy position, and then the lines for the anterior superior iliac spine and costal margin are also drawn. And by this way, the flank region is elevated, and we can have enough space for both retrograde and antegrade access. And the operating room setup is really very important. As you can see, this is a theater for a patient who is underwent ACRS. And we are operating for the left kidney stones. And this is the surgeon doing the PCNL, and this is the surgeon doing the retrograde intrarenal surgery. And this is the tower for the PCNL, and this is the tower for the flexible ureteroscopy. The C-arm comes from the opposite side, and the screen of the fluoroscopy machine is also on the opposite side. And we have just one scrap nurse, and she is just assisting both of the surgeons with two separate tables. However, if you do have a tower that has the probability of a split screen, and then it's just placed at the opposite side of the PCNL surgeon, and both of these surgeons can work from the same tower. This gives you a lot of space, and by this way, we can take the fluoroscopy screen into the ipsilateral side, and also again, the scrap nurse is helping both of the surgeons. So the puncture is the most important step of PCNL, and our objectives while doing the puncture is, first of all, to provide minimal trauma to the kidney and parenchyma with minimal radiation. And we need to reach the maximum stone burden through our puncture. And if possible, I always advise to make the puncture through the papilla. And in order to establish these goals, first of all, we need to have a good preparative preparation. And in order to do that, in my opinion, a preparative CT scan and axial imaging is mandatory. Also, using ultrasound intraoperatively or perioperatively really helps to avoid any injury to the adjacent organs like liver, spleen, or pleura, or the bowel segments. And usually a contrast study is not necessary preoperatively, but we can do a retrograde pyelogram during the operation in order to understand the anatomy of the collecting system. And at this step, actually, if you have the opportunity to use the flexible ureteroscope, a direct examination of the entire collecting system with the flexible scope usually helps a lot. And so the key message here is the successful puncture is the key to the successful PCNL, and we should just plan our surgery very well. And we can do the puncture with the help of some imaging modality, and we can use either fluoroscopy or ultrasound or endoscopic guidance. Whenever possible, we can also combine these imaging modalities. First of all, I'll start with the fluoroscopy-guided puncture techniques. And in the currently available literature, there are three methods that has been published. The first one has been published by Dr. Andreas Hosneck from France. The second method was published by my dear friend Braulio Manzo from Mexico, together with the group from Fundacio Hugewert. And the last method has been published by our group. And I will go over all of these one by one with the help of some videos. The first method has been published by Dr. Hosnek, and this method has been applied by many of our colleagues. And this is also the method that I used when I first started doing supine PCNL. In this method, what we do is, first of all, the patient is placed in the Galdacan modified supine Valdivia position, and then we do the retrograde pilogram and determine the target calyx to be punctured. And then in order to just point this calyx, a clamp is placed on the surgical drape under the fluoroscopy machine. And then the puncture is made actually at the posterior axillary line in a single plane. And then when the needle is introduced and it just matches the clamp on the skin, then there are three possibilities. Either if we are lucky, the tip of the needle is in the correct place, or it's anteriorly or posteriorly located. So we need to check the depth of the needle with having another plane. So in order to establish that, what Dr. Hosnek says is the C-arm is tilted craniocaudally in this way. And at that time, continuous fluoroscopy is applied, and there we are checking the tip of the needle and the clamp. And as in here, if they are going away from each other, then it means that the needle is posteriorly located. So it should be retracted back, and a more anterior puncture should be performed. And this is the original video from this publication. And after placing the patient in GMCY position, the body is actually rotated 15 to 20 degrees, and then a monoplanar puncture is being performed. And first of all, this clamp is placed on the tip of the target calyx under fluoroscopy to point it out. And then the needle puncture is performed under a single plane. And in order to check the depth of the needle, the C-arm will be tilted in a craniocaudally fashion. So this develops a second plane, and therefore, in the fluoroscopic image, if the tip of the needle and tip of the clamp are going away from each other, as it's shown in this video, then it means that the tip of the needle is posteriorly located. So it should be retracted back and then introduced more anteriorly. Actually, this is a very nice method, very convenient. However, there are some problems with this method, that's because I started by using this, but then shifted to another method. And this is a live case. As you can see, after introducing the needle, the C-arm is tilted and the tip of the clamp and needle are going away from each other. This means that the needle is posteriorly located. So the main problems is, as you can see, the surgeon has to apply continuous fluoroscopy during the tilting of the C-arm in order to determine the relative position of this tip of the needle and the clamp. And it increases this fluoroscopy times. It's the problem. And another problem that I face is we usually place the legs with a leg holder in the operating table. And when the C-arm is tilted, the C-arm usually crashes with with these leg holders. They are because they are extending under the table, and sometimes it just interferes with the movement of the C-arm. So it becomes some problem. And in our method that I'm going to mention later, we also compared the fluoroscopy times with this method, and fluoroscopy times are quite long when you apply this method. And the second method has been published by Dr. Braulio Manzo from León, Mexico, together with some colleagues from Spain, Dr. Oriol Anheri and his group. And this method is really a nice method because you can use pulse fluoroscopy. And together with that, it's just something like the bullseye method that we apply in a prone position. In this technique, what they do is, again, we do the retrograde pilogram, and the desired calyx is selected. And it's just pointed out with the help of the needle under fluoroscopy, and with a surgical marker, a point is dotted here. It's the point A. And then the second step is to determine the level of puncture at the skin. And in order to determine that, the C-arm is rotated to 0 degrees now. And we determine the tip of the target calyx again here, and determine the level. And this red line here is the line B. And this level will be the point of puncture, the depth of the puncture. And we will just go through this line parallel to the floor. And then the C-arm will be again rotated to 90 degrees in order to determine how far we will advance the needle.
I will interrupt here once.
Okay.
You said parallel to the floor. I have seen all supine PCNL, most of the punctures, you need not tilt the needle. Most of it is parallel. Do you agree with that? Most of these supine PCNL punctures are parallel.
Yeah, we usually go parallel to the floor, and it's really an advantage because at that time, the outflow is really free and your irrigation fluid comes out spontaneously, and it provides lower intrarenal pressures. And that's why the risk of septic complications and fever are less in supine position. Yeah, that's an important point.
And the tilting of the patient is also, we need not worry that much because of this horizontal puncture.
Yeah, absolutely. That's correct. We don't need to turn the patient a lot. And also this gives us a good anatomy for the renal puncture. The kidney is just lying in front of us with the lateral plane. So we can make the puncture either through the anterior or posterior calyx. It's really an advantage.
Right.
Okay, so I'll continue with this video. And here, first of all, they put the needle on the skin, and under fluoroscopy, they determine the level of the target calyx and make a point here. It's the point A that just shows us the target calyx. And then the C-arm is taken into the 0 degrees position now. And with the help of the needle, with pulse fluoroscopy, not continuous, the line B is determined. This is the level where the needle will go parallel to the floor. And then they join the point A, the first point, and this line. And this point here is the exact puncture point in the skin. So with the help of the blade, an incision is made and the needle is introduced just parallel. And at this time, the fluoroscopy is still, the C-arm still in the 0 degrees down. So this is something like the bullseye from the prone position. And then the C-arm is again rotated to 90 degrees in order to get the anteroposterior image and how far we should insert the needle. The depth of the needle is determined in this way. So this is also a good puncture method. And using the pulse fluoroscopy really limits the fluoroscopy times, and it's easy to learn. And from their perspective, after doing 5 or 6 cases, it's possible to do the puncture by the surgeon himself. But one of the things that I consider with this technique is the C-arm is in the ipsilateral side. So it's just next to the person, next to the surgeon. And it may be sometimes a problem because it's just some obscuring the area. And you have to take the C-arm away after doing the puncture in order to make the other part of the surgery. And having the C-arm just next to you may be sometimes problematic while doing the dilation as well. And another problem is while rotating the C-arm from 0 to 90 degrees, it just goes under the table. So, and that area is not sterile. And I have some concerns about the sterility as well while applying this method. But other friends also, we just talked about this. Some of our colleagues also say that you can do this, apply this technique with the C-arm coming from the opposite side as well. So I think it's a better way to use this technique.
What do you recommend, ipsilateral side or opposite side in your routine theater?
I always use from the contralateral side because next to me, C-arm, it's just occupies a lot of space, and I have to just take it away while I'm doing the lithotripsy. So I don't consider it a good option to have it next to me.
Yeah, just a matter of doubt. In prone PCNL, can we do at all the C-arm in the same side, ipsilateral side? Can the prone PCNL be done with the C-arm in the same side? Can be done.
Yeah, it can be done, but I think from the opposite
Difficult.
side, it's a much better option, I guess.
Yes, okay.
Mm-hmm. So this is the last fluoroscopic method that I would like to mention, and this is actually published by our group in 2018. And again, here the logic is you need to have two different planes, and just intersection of these two planes will give you a line in the space that will directly take you to the desired puncture point. So just to explain what this schema shows us, this is the C-arm. The black is the operating table. This blue one is the patient. Yellow one is the kidney. And the red dot in the middle is our target calyx. So we do the retrograde pilogram and determine the target calyx to make a lower pole puncture here. And we first make the puncture under a single plane and try to hit the center of this calyx. And then this fluoroscopic image shows us that there are three possibilities. If we are lucky, the tip of the needle is in the correct place, so there's no problem. But it may be also anterior or posterior to the desired calyx. So we need to check it with the help of a second plane. So we just rotate the C-arm 5 to 10 degrees to the opposite side, and then get another image from the fluoroscopy device. So this red dotted line is the level of the needle from the first image. From this green line, these are the same. And now after rotating the C-arm, the tip of the needle does not reach this point. So it means that in the second image, if you have this vision, it means that the needle is anteriorly located. And the opposite is also correct. If the needle exceeds through this level, it means that the needle is posteriorly located. So if it's in this position, the needle should be retracted back and do a more anterior puncture. And if you have this kind of image, just retract it back and make a more posterior puncture. So with the help of two planes, we just determine the depth of the target calyx. And this is an example from one of the cases that we performed. We are operating on the left side of the patient, and we are trying to do an upper pole puncture in this case. So first of all, we do ultrasound and determine the exact puncture point that will take us to the target calyx. So we make the puncture under fluoroscopic control in single plane, and we hit the target calyx like this one. And we just determine the level of the tip of the needle. And then the C-arm is tilted 5 degrees, and we develop the second plane. And at this time, the tip of the needle did not reach the level from the first image. The green line is from the first image, and the red line is from the second image. So it means that the tip of the needle is anteriorly located. So we retract it back and make a more posterior puncture. And this is the new image, and we compare it from the first image by tilting 5 more degrees the C-arm. And at this time, the tip of the needle just matches the image from the first one. So it means that the tip of the needle is in the correct place. We just make a secondary plane and check the depth of the needle. And at this time, we also use the pulse fluoroscopy. This significantly reduces the fluoroscopy times. And also, it's really very easy to use. And the C-arms comes from the opposite side, and therefore it doesn't interfere with our surgical area. And it's really very easy to learn. And in our department, our residents usually can do their own punctures after 7 or 8 successful cases. So I will continue with the ultrasound guided puncture here. This ultrasound guided puncture is really important to be applied because it significantly reduces the radiation time. And also for ultrasound guided puncture, you can either use a needle guide or freehand puncture technique is also available. At the initial time of the learning curve, actually you can apply the needle guide. You can use the needle guide, but I really don't like it a lot because usually with the freehand guided puncture, you have more available space to reach your target calyx, especially while doing the upper pole punctures. The costal shadows usually obscure your image in the ultrasound. So with the help of the freehand technique, you can do a much easier puncture. However, combining ultrasound and fluoroscopy is a better option because, and if you are even doing this ultrasound guided puncture, I advise you to always have the fluoroscopy readily available in the operating theater because you will need the fluoroscopy after puncture for tract dilation and sheet placement as well. And this is an example of total ultrasound guided tract creation. We first make the puncture under ultrasound guidance and then put the guide wire, and we are doing mini PCNL, and under ultrasound guidance, we can also put the sheet, the dilator and sheet placement as well. However, this is possible only when the kidney is really dilated significantly. But I always try to have the fluoroscopy readily available in the operating room as well, but just use it with the ALARA principle as low as reasonably achievable. But while doing the tract dilation and sheet placement, usually doing it with one of your hands and inserting the dilator with the other hand, it's really very hard. So I usually do these, I almost always do these steps under fluoroscopic guidance. And the last method that I would like to mention is the endoscopic guided puncture method. And in this method, what we do is we use the flexible ureteroscope to navigate the entire collecting system. Sorry, there are some problems with the videos. We just do these endoscopic imaging of the entire collecting system, and then just determine the exact puncture point, the desired calyx, and do the puncture usually with the ultrasound or fluoroscopic guided puncture to check the direction of the needle. And we are just making sure that we are in the collecting system with the help of the endoscopic view. And we can also make sure that we are hitting through the papilla. And if we are not happy with the puncture, then we can just retract the needle back and make a better puncture as well. But this is not, endoscopic guided puncture is not always possible. The main problem with the endoscopic guided puncture is usually these stones occupy an important part of the collecting system. So we usually have the stone just occupies the desired calyx, so we cannot get into the calyx, and we cannot see the needle. But even at that time, we can see that the needle is moving this stone, and by this way we can make sure that we are in the correct calyx. And also by introducing the guide wire, we can say that the guide wire is in the collecting system, or even with the help of a basket, we can take the guide wire down through the ureter to make a true access. So endoscopic guided puncture is a valuable tool, and it can be applied whenever possible. It significantly reduces the fluoroscopy times. For example, if you are using a balloon dilation, then you can just do it without any fluoroscopy, just insert the balloon and check the position with the help of the flexible ureteroscope, and by this way, do all of the steps under direct endoscopic vision. But still, you will need either fluoroscopy or ultrasound in addition to the endoscopic guided puncture. So actually, it's important to have all of these imaging modalities with you. None of them actually works perfect alone, but having fluoroscopy, ultrasound, and if possible endoscopic guidance will lead you to successful puncture. And Actually, if there are any questions up to so far, we can just answer those questions, or we can just continue with these tips and tricks for the special situations.
A few questions from the box as well as from my side quickly. First one is lower pole calyceal stone impacted. To reach in supine PCNL, sometimes your puncture point may go below the iliac crest on the fat of the thigh. In such cases, the tract of the length tract will be long needle. As a junior, anybody will be afraid to manipulate with 80% of the needle going inside. So over a period of time, we are making a little angle to the calyx, not exactly through the calyceal cup. We will come above the iliac crest, make horizontal puncture towards the lateral aspect of the calyx, not exactly inferior aspect of the calyx. So do I want to comment impacted stone lower calyceal, particularly with an acute angle, infundopelvic angle? Any tips and tricks you wanted to give?
Yeah, that's actually, those cases are really hard ones. And you're quite right. With the low riding kidneys, sometimes the puncture point is just next to the anterior superior iliac spine, and you don't have enough space to make a puncture with a good angle. And you need to go just parallel to the calyx as well. And these are problems. And actually, these are not perfect punctures. And sometimes the needle really goes very deep into the patient. But at that time, I strongly advise to use ultrasound in order to check for any bowel segment.
Right. Yeah.
Because after the kidney ends in the horizontal section, there may be a colon segment just in the inferior part of the kidney. So checking with ultrasound is really helpful in those cases. And the second one is using ECIRS. Maybe a good option if your flexible scope can go through that lower pole. We can just make some laser lithotripsy and take those fragments into the pelvis and make a puncture from the middle pole. That may be an option. And also another problem, especially in supine position, is the mobility of the kidney. The kidneys can be quite hypermobile because like the prone position, we don't have the abdominal support in those cases. And we actually published a study in this manner in order to determine the factors that are having effect on the hypermobility of the kidney. We usually think that the thin patients have more hypermobile kidneys, but in our study, we find that not the BMI of the patient is an important factor, but the thickness of the perirenal fat is an important parameter in that study. If there is less fat around kidney, then it's more mobile. And also the length of the renal artery is also important because it's a stiff structure and also it may fix the kidney. But in those hypermobile kidneys, what we can do is we can apply some pressure from the anterior abdominal wall with the help of our hands or with a surgical, with a sterile piece of material. And also we can make a puncture and do the true access. Just hold both of the guide wires, one side from the skin and one side from the urethra. And by this way, the kidney may be fixed for the dilation process. But hypermobility can be sometimes a problem in those cases, especially when you do the lower pole puncture, the kidney just moves like this, even to the opposite side of the vertebral column. It sometimes occurs.
The second point is, if you are puncturing below the 12th rib, between the iliac crest margin and the 12th rib, most of the supine PCNL punctures appear easy, and you succeed, and you will enter and go into all the calyces except deep inferior calyx. Rest of all the calyces can be approached. Whatever may be the size, position of the kidney, if your puncture is below the 12th rib, in the posterior, 2 finger breadths posterior to mixaxillary line, looks very easy. If at all that calyx is suitable for your stone, it goes very easily. Any comment on that?
Yeah. Actually, one of the advantages advocated for supine position is exactly this point that you mentioned. If you do a lower pole puncture, then you can reach the upper pole calyces from that puncture as well. And this
Yes.
was well published by Mario Sofer with a nice study in Journal of Urology. But the main problem is you can reach the upper pole with your rigid nephroscope, but it doesn't mean that you can reach every calyx, because the calyceal anatomy sometimes can be very complex, and there may be some posterior calyces that some of them may be with the acute angles. So you can reach the entrance of the upper pole and most of it, but not every calyx. So we also did a study in this manner in order to check the value of the retrograde flexible ureteroscopy to check the entire collecting system for residual stones in patients with or we operated with ACRS. And in that study, what we did was at the end of the operation, we first of all introduced the flexible scope from the percutaneous access sheet in order to check the entire collecting system, and then did the same with the retrograde approach as well. And we find that we were not able to navigate the entire collecting system in more than 25% of the cases with the antegrade approach. And in 18% of the patients, more importantly, we found some residual stones with the retrograde access. It means that yes, we can go through the lower pole, we can reach the upper pole, but it doesn't mean that we can navigate through the entire calyceal system. It's not always possible. So that's why I always may have flexible ureteroscope readily available during my PCNL. If a fragment just passes to the other parts of the collecting system, I would like to follow it with my flexible scope with the retrograde approach.
Correct. Fantastic. We'll go ahead then.
Mm-hmm. Okay, so I'll just try to give some tips and tricks for special situations. First of all, in supine position, doing the upper pole puncture is usually advocated as a disadvantage. It's said that you do not have enough space. But as I mentioned in my position photos and also videos, the space is quite available. And also I'll go over some anatomical abnormalities as well. So this is the first case. This is a 76-year-old male patient. He has a huge stone burden, a 25-millimeter stone in the right upper pole and another one in the renal pelvis, and two separate stones in the lower pole. So this is a young gentleman, and as you can see, the kidney is a little bit low riding. This is our position, and there's enough space for upper pole puncture. And using ultrasound combined with fluoroscopy is really helpful here. We are doing the puncture under ultrasound guidance. We are checking for the liver and also the bowel segments, and there is no problem. And we just confirmed that we are going through the papilla with the help of the fluoroscopy as well. And after doing the first puncture, as there was also stones in other parts of the collecting system, I planned a 2-tracks PCNL in this case. And the second puncture is performed under fluoroscopic guidance, but we check the level of puncture with the ultrasound and just do a puncture parallel to the floor. And I always like to do all of my punctures prior to track dilation and place my guide wires, because the collecting system is filled with contrast. And by this way, it's a much better option to do all of the punctures prior to dilation of the first tract. And this is another one, a 47-year-old male patient with horseshoe kidney. He has history of failed RIRS, and there's a 20-millimeter stone in the renal pelvis and other stones in the upper pole as well. And in these horseshoe kidneys, actually from the prone position, we are also more familiar with the upper pole punctures because they are much more convenient for puncturing. And in these cases, the position is more or less the same, but the patient may be rotated some more if you need a more posterior access. But the position is more or less the same. Nothing special is needed. So we first do an ultrasound in order to check if the spleen or bowel segments obscured with our images, but it's quite clean. There is no problem. The window is open. So we do the puncture with the help of both fluoroscopy and ultrasound again. And freehand puncture really helps us a lot in this manner. While doing the ultrasound guided puncture, actually using some special needles may be helpful, like the eco-tip needle. It's really you can see it very easily under ultrasound. And then after doing the upper pole puncture, we did the 15 French metallic dilation and 16 French sheath insertion. And the stone is fragmented with the holmium laser, and the direction of the sheet is parallel to the floor. So with the help of the vortex effect, the stone fragments are evacuated very easily. And after that, as the retrograde approach was not possible in this patient due to the narrow ureter, we did the antegrade flexible nephroscopy and took out all of the fragments, and the surgery was ended with a double J stent. So in horseshoe kidneys, using ultrasound and fluoroscopy is really a good option. You don't need to do anything special if the kidney is favorable. And also another point is you don't need to go through the upper pole always in supine position. If the stone is in the pelvis or in the lower pole, you can go through the middle pole as well. And just with some very mild angulation, you can reach the renal pelvis and the lower pole calyceal system very easily. And this is another case. This is a 60-year-old male patient. He has a solitary kidney. The right kidney is atrophic. And there are two stones. One is 2 centimeter stone in the upper pole and a 22 by 15 millimeter stone in the renal pelvis. And this patient has recurrent urinary tract infections, and he has history of failed RIRS, and a narrow distal ureter was reported in another center. Despite perstanding, it was not possible. And as the patient also has history of significant UTIs, we actually decided to go with mini-perk in this patient. And when we did the ultrasound, the spleen actually covers the window in order to reach this upper pole calyceal system. Actually, during my surgical planning, I wanted to do a lower pole puncture and clear the stone in the renal pelvis. And then, if possible, I planned to go to the upper pole from that puncture, but it was not possible. So in those cases, we need to go through the upper pole, but spleen covers it, and it's in the 10th intercostal space, so it's a really problematic thing. So in those cases, we can use this renal displacement technique. This technique has been published by Dr. Mehmet previously, and with the help of the puncture needle or a dilator, we just bend the kidney down very gently, and the upper pole comes into a more favorable space, and we can do the puncture in a safe manner. So this is the fluoroscopic image from the surgery, the stone in the renal pelvis and also upper pole. And we first of all made a lower pole puncture in order to reach the stone in the renal pelvis under fluoroscopic guidance. And then a 15 French metallic sheet, a metallic dilator, and the 16 French sheet is inserted over the dilator, and we reach the stone in the renal pelvis. We make holmium laser lithotripsy in order to clear the stone, and the fragments are taken out with the vacuum cleaner effect, the vortex effect. You don't need any basket or forceps to take those fragments out of the system. And after clearing all of these stone fragments, we need to do the kidney displacement methods. And to do it, what I advise is to place a guide wire down through the ureter. And then the dilator is introduced over the guide wire, and we just bend the kidney down very gently. My resident just keeps the dilator in this knee position, and we are able to reach this upper pole from the 11th intercostal space, just above the 12th rib. So it's a much safer puncture. We again do fluoroscopy guided puncture. And then the steps are the same. The guide wire is inserted, and then 15, 16 dilation and sheet placement. The stone is fragmented with the help of the holmium laser, and all of the fragments are taken out. So we were not able to reach this calyx from the lower pole puncture, and this was the problem. And as we did not have the flexible scope, available to go through the ureter due to the narrowing of the distal ureter. Then we did this upper pole puncture with the renal displacement technique. Actually, doing upper pole puncture is usually safe and easy in supine position, but checking with ultrasound is a good option, good alternative. We can also apply some respiratory adjustments that we all know from prone position, but if they are not helpful, then using this kidney displacement technique is a good option. But while doing that, having the guide wire down through the ureter is a good option, because otherwise your puncture needle or the dilator may give some harm to the epithelium of the ureterium of the collecting system. So having the guide wire down the ureter and having the dilator over the guide wire is a better option. And this is the last case I would like to mention. This is a 25-year-old male patient presenting with a pelvic ectopic kidney, right side. He has a huge stone and he has previous history of flexible uroloscopy in other centers, but they were not able to reach those stones. And these are the axial images. As you can see, the bowel segments are just occupying the entire space to reach this kidney. And the stone is quite hard, over 1,000 Hounsfield units, and the size is huge. It's more than 25 millimeter in diameter. So in these cases, what we do is we get consent for both laparoscopic pyelolithotomy and also laparoscopy-assisted PCNL, and decide during the operation to go through. First of all, check with the ultrasound if there is available space to go with PERC approach, but usually in those cases it's not possible due to the bowel segments. And then we continue with the laparoscopy, put 3 different ports, and just release the bowel segments. In this case, the ascending colon is medialized in order to try to reach the kidney. And after reaching the kidney, it's just we try to dissect the renal pelvis to go through the pelvis. But these cases usually have some different difficult anatomies for vascular structures. And together with that, due to the stone in the renal pelvis, there's marked inflammation around the renal pelvis, and the tissue is really very sticky, and it's not easy to dissect the renal pelvis in those cases. So if we are not able to dissect the renal pelvis, then it's really important to not to release the kidney a lot, not to dissect, because then it becomes much more mobile and puncturing will be much more harder. So we also place a retrograde ureteral catheter previously and inject some contrast. And then under direct laparoscopic view, we do the renal puncture under direct vision. There's no bowel segment around now. And with the help of the fluoroscopy, we make sure that we hit the target calyx. And with the help of the laparoscopy, we are sure that we are not giving any harm to any other structure. And after placing the guide wire, again, the dilator and the sheath are also inserted under direct endoscopic vision. And we also check the depth of the dilator and the sheath with the help of the fluoroscopic guidance. So this is the operating room setup. This is the PCNL surgeon, and this is a laparoscopic surgeon. He's just checking the screen for any bleeding. And in those cases, having a longer sheath is usually helpful because the distance from skin to the stone is longer compared to the regular cases. So we usually have an 18 centimeter mini sheath here as well. And as this is a transperitoneal surgery, also having a miniaturized tract is really helpful. With a standard tract, then the risk of bleeding is much higher because we are now not working in the retroperitoneum. And this stone was quite hard, and at the time we had a low power holmium laser. So instead we just make the fragmentation initially with the help of the 4 French ballistic probe. and the stone fragments are taken out of the system again with the vortex effect, and then continue with the whole beam laser, further fragmentation and clearance of the fragments. And another tip here is we usually elevate the abdominal pressure during the puncture and the dilation in order to prevent the risk of bleeding from the renal parenchyma. But after putting the sheet inside the kidney, we drop the pressure till the end of the operation to the normal levels. And in those cases, the exit strategy is to place a double J stent for drainage of the collecting system. We do not place a nephrostomy tube, but put a abdominal drain also in order to monitor for any bleeding or urine extravasation postoperatively. And luckily in this case, we were able to reach all of the stone in the collecting system, and all of the fragments were taken out of the system. And at the end of the operation, we just put a double J stent into the collecting system for drainage, and then drop the intra-abdominal pressure to 8 millimeter mercury and check for any bleeding. And an abdominal drain is also placed around the kidney to monitor any postoperative bleeding. So at this step, the sheet is just extracted. No sutures or nothing has been placed. The total operation time was 85 minutes. We took the drain out at the end of postoperative day 1, and the JJ stent was extracted at postoperative day 10. And this is the KUB postoperatively. So these are the cases that I would like to show today, and I hope that we had a good discussion about the puncture methods in supine PCNL.
Thank you very much. We'll have a quick fire questions, maybe 10-15 questions, and then we will conclude. That's an excellent talk with a lot of, as I expected, I have seen only 8 minutes talk. Now this is a elaborative talk. Questions related to the supine PCNL. Have you done prone PCNL also for a period of time in your career?
Yes, I was trained in prone position.
What cases do you think now, after seeing the CT, what cases do you think that prone may be better?
Okay, so I believe that you can do anything in supine position. If you are doing in prone, you can do anything in supine position as well. The only problem may be actually there may be some skeletal deformities in some patients. So in those cases, maybe sometimes the kidney is just at the very back of the patient. So in that case, doing a prone PCNL is a better option. Like the
horseshoe kidney. Prone is slightly better because it's all anteriorly mal-rotated in situ kidneys. Anteriorly mal-rotated in situ kidneys, in the sense normally located in the L1, L2, L3 region, are slightly difficult for supine.
Yeah, that's correct. I personally have now more than 40 cases of horseshoe kidneys performed in supine position. If they are just like the regular kidneys, then there's no problem in supine position. But you know, as you mentioned, the very mal-rotated kidneys may be sometimes problem. Yeah, I agree with that. But in those cases, again, you have to go very medially in prone position, and it also has its own risks. So in those cases, what I also prefer is to go with lap-assisted PCNL in supine position. Just release the kidney a little bit and make a more safe puncture, because going so medially also has some problems with the spinal cord as well. I don't like to take that risk.
Yeah. In India, we don't use ultrasound so often. Most of the Indians are used with the CM. But after I have taken the BK ultrasound 2 years back, I feel that one minute of ultrasound imaging before you puncture will give you much better idea, safer puncture in relation to the viscera as well as the location of the puncture. Do you think in future ultrasound usage will be much more than present now?
Yeah, absolutely. It's the way to go. I mean, ultrasound is a very versatile tool. It gives you a lot of information and live information because you get the information preoperatively from the CT scan. And that CT scan is actually performed in supine, complete supine position. So, for example, what I mentioned is if you are doing your surgeries in prone position, have your CTs in prone position as well. That's really important because when you turn the patient prone, and at that time, the kidneys move from posterior to anterior. And then the bowel segments move from lateral to posterior. So it's completely different anatomy. That's why the risk of colon injury is higher in prone position. And in supine position, also, we do not do the CT scan in the original operating position. So therefore, having the ultrasound as a dynamic imaging prior to operation or perioperatively during the operation is really very valuable. And you're right, the use of ultrasound will increase a lot in the future.
Third question. Normally in supine PCNL, when you go into the kidney, you will go into most of the times anterior calyx. However, after that, negotiation to the ureter, pelvis, and even in posterior calyx is much better than prone. So any anteriorly located slightly larger stone, supine has definitive advantages, I feel. A comment on that.
Yeah, absolutely. I actually had a case of anterior calyceal stone yesterday. And actually, from the CT images, I was quite sure that operating in prone position in that case is impossible. And yeah. I mean, you have to puncture a lot of parenchyma in order to reach that stone. But with supine position, we were just able to go to that very anterior calyx. It was a narrow neck. The flexible URS was impossible. So it was just 25 minutes of surgery, 18 millimeter stone, and the patient is stone free and discharged the next morning. So it's really quite valuable. But one concern about that, the lower anterior calyces, the lower pole anterior calyces, I mean, they may bleed terribly. So if you have stone in that calyx, and you have no other option, then you have to do that. But otherwise, puncturing that anterior lower pole calyx may be sometimes problematic. And I have two cases of angioembolization, and both of them were the lower pole anterior calyces. And
anterior medial calyceal stone are very difficult, never to be attempted casually. Angle inferior pelvic angle is also important for supine prone PCNL, also not only for RARS. So somehow the parenchyma is thick, bleeding is more, the arteriovenous malformation chance are more. We all feel that a little more bleeding happens in calyx, medial anterior stone. And
absolutely.
If the supine PCNL puncture, the movement of the kidney, not only the movement of the kidney, but also the movement of the calyx, not only the calyx movement, the cup dipping. Cup dipping gives a fair idea that you are almost going to enter, so that monoplanar C-arm is more than sufficient in most of it. All you need is to go to the kidney movement, then calyx movement, then cup also moves so much towards the spine. You know that you are entering it.
Yeah,
this
absolutely.
Much safer than prone. What do you say?
Yeah, absolutely. And as I showed you, 3 different methods of fluoroscopy guided puncture, but in more than 80% of my cases, I can do my puncture in a single plane. But doing an ultrasound prior to puncture helpful to determine the puncture point and the depth of the needle. And as you said, the image in the fluoroscopy, the dimpling of that calyx gives you a good idea, and you are quite sure that you are inside that calyx.
Next, the posterior axial line is like very important line. There is no important line in prone. Prone important is rib and rib. Whereas in supine, a rib also is a very important landmark, I feel, apart from posterior axial. If you have any confusion, feel the rib and then go. So what, where can you go wrong with posterior axial line? If somebody keeps only posterior axial line as the line cutoff, can colon be injured if you are sticking on to posterior axial line?
Yeah, it's actually possible. That's why we always have a CT scan preoperative. If there's a retrorenal colon, then it means that there's risk of injury even you go posterior to the posterior axillary line. So in those cases, always check with ultrasound if there's an open window for puncture, and if not, do laparoscopy to take that bowel segment medially and make your puncture.
That is possible in supine PCNL easily.
Yeah, absolutely. Even just rotating the patient a little bit more, you can do the laparoscopic approach.
After 10 minutes, we can flip off the colon and then come back with basic principles of fluoroscopy and puncture.
Yeah, absolutely. Absolutely.
You said the very important video I am impressed is the supracostal puncture can be made easy by lower pole and then bringing it down. Do you think that needle, I feel needle cannot push the kidney down? A little bit dilatation up to 12 inch. Yes, needle and Alken rods are dangerous to push the kidney down. It may injure the PCS or parenchyma. So do you think that what amount of dilatation, ampla sheath or anything, nephroscope? I think 12 French nephroscope can put it down very, very effectively.
Yeah, absolutely. But in the original paper of this renal displacement technique, they did it with the metallic needle. But you're right, it's not always possible because especially if the distance from the skin to the pelvic calyceal system is long, then the needle is not sufficient to bend the kidney so much. So at that time, having a dilation of about 10 to 12 French may be a good option, but I usually prefer it if there are stones in other parts of the kidney, like lower pole or renal pelvis. So make the lower puncture, lower pole puncture.
Yes.
Hello? Yeah, I can hear you.
In last couple of questions. In supracostal puncture, spleen and liver to avoid injury, do you have to go little lateral to the mid-scapular line and then go to the lateral part of the calyx is much safer than the end of the calyx superiorly, unnecessarily going medially? What is your, if at all ultrasound is not available, what tips and tricks you will give for supracostal supine PCNL puncture? Medial or lateral? Oblique tract from the below the rib, or you can take experiment above the 12th rib?
Yeah, and this is really a hard task, and I always advise to have ultrasound available. So
yeah,
and if it's not available, then instead of doing some movements under the skin, I can advise to make that renal displacement technique. Make a lower pole puncture, bend the kidney down, and do your puncture in the 11th intercostal space. It might be a much safer option because otherwise you make some movements under the skin with your needle, some zigzags, but you may not be sure that you are puncturing through the liver or spleen. So, and it sometimes happens, yeah. So actually, I cannot make a wise comment on that. What I can comment is have an ultrasound available or send the patient to somewhere where ultrasound is available.
Very nice, very nice. The last question. After the retrograde intrarenal surgery has become popular, now how I personally feel access sheath as the ureteric catheter, smaller access sheath, and flexible scope to inject contrast in a difficult cases, in a calyceal large stone, 2-3 calyces which are complex, helps a lot. Are we going to use flexible scopy in the future PCNL cases will increase or not? What is the role of ECIRS in future from your experience? I have increased it. 20-25% cases. I'm just going and watching all the cases, happy if I have cleared. Otherwise, I'm seeing some of the fragments in different cases. When I take them out, I feel very happy. So you mentioned already that 18%, but from your point of view, role of ECIRS in future in stone management.
Yeah, actually, ECIRS has been my standard for complex cases initially, but now it's my standard for almost every case. Yes. So I believe that having the direct imaging, the diagnostic imaging of the entire calyceal system from the distal urethra to the upper pole calyx, it's really helpful. And maybe it may not aid in puncturing in all of the cases, but at the end of the operation, searching the calyces for residual fragments is really helpful. And as this in the study, as I mentioned, that we published, the positive predictive, the negative predictive value of doing this retrograde searching of the collecting system is 96%. So you can avoid having a CT scan or postoperative imaging with the help of this maneuver. Of course, it has some drawbacks. It's an additional expense. The flexible scopes are expensive. You may not have a dreadle available. Okay, these are the drawbacks, but from my point of view, ECIRS is the standard procedure for every case. And we are actually, we are doing a lot of RIRS surgeries as well for even bigger stones with high power lasers and the TFL lasers. But in those cases, the problem is the patient has to pass the stone still after the operation. So this is a main drawback. And we should always keep in mind that ureter is a very fragile organ, and always keep it safe than sorry. And I always tell my residents that this stone is the disease of the kidney. And in order to reach that stone, you have to pass through 3 different organs. And instead of damaging that, doing a mini PCNL in supine position may be much more safer. So we should just decide based on the patient anatomy and stone-related factor. And in conclusion, it's the PSA, personalized stone approach.
So thank you very much. We have spent good amount of time on this supine PCNL. Really enjoyed personally myself. I am gone into the depth with your presentation. Nearly 200 audience were on live. That's big number. And by tomorrow it will reach 1,000 audience because the same link will be there forever. So we are very happy to have eminent speaker like you for supine PCNL in pure urology. Thank you once again. And we will conclude the session. Thank you.
Okay, I'd like to thank you so much for invitation and also this great organization. I actually sent all of the links of pure urology to my friends as well, and they are really amazed with this. And I hope we will participate much more in the future. Thank you, Dr. Chandra.
Thank you very much. Thank you. See you. Bye-bye.